Good morning. I don't know if I've ever had to follow butt clenches on the stage before. This is new. Always happy to be back in Stockholm. I'm going to start with a story today. This is my kitty. A friend of mine moved into a new apartment, and there was a resident stray cat in this apartment. And she started talking incessantly about this cat. She gave it a name, she was feeding it, she was letting it come and go as it pleased, she was taking it to the vet, she was buying it toys, but she would always say at the end of a story, but it's not my cat. And we would all look at her like, okay. And finally we laughed and we said, you realize this is your cat, right? And she was the last to know that this was her cat. Well, I had an experience like this recently where someone referred to me as a healthcare designer. And I said, but I'm not a healthcare designer. I've designed all kinds of things. And my friends gave me that look. And so I thought about it. And I realized, 30 years ago, oh, that's a scary number, I started on my first healthcare products. I was doing illustration and animation for health education products for managing hemophilia and cystic fibrosis and general health stuff like nutrition and so on. So yes, that's 16 colors, picking away a pixel at a time in Microsoft Paint. Stones, chisels, all of those primitive tools, but it's sort of meditative. Since then, I've done all kinds of healthcare products. I've done or led product and design teams that have done a bunch of different electronic medical records, chatbots for mental health for teenagers and adults and new moms, medication infusion pumps used in hospitals, glucose meters, insulin pumps for managing diabetes, big online pharmacy website, speech therapy for managing rehabilitation after a stroke or a brain injury, radiology products, nursing home management tools, cancer treatment, medical research platform, patient and caregiver social network. I guess I'm a healthcare designer after all. So yeah, there's some other stuff too. I don't remember it all, honestly. So I added it up, and I think I've probably spent maybe 60% of my career doing healthcare stuff. And it's fine. It's fine with me. I've accepted that I'm a healthcare designer, because you know what? I love healthcare, actually. The work is intellectually really challenging because, healthcare is complicated in so many ways. It's emotionally challenging, especially the user research, because you hear just gut-wrenching stories. And it's so, so rewarding because you see what a difference you make in someone's lives. I'll never forget the first time a nurse broke into tears when she saw the design of the new product that was going to help her. She said, I would have taken better care of my patients all these years if I'd had this tool. I was like, oh, okay, this is why you do this work, right? So it's powerful stuff. So when the conference organizers said, can you talk about lessons learned from healthcare that apply broadly in design? I thought, well, yeah, because healthcare has really shaped a lot of how I think about and practice design. It's shaped my values, it's shaped a lot of how I work. And I do think that even if you don't work in that field, there are things we can learn about responsible product development, about politics and power, and about human beings from healthcare. So I'd like to share a couple of those today. Some years ago, one of my teams and I were working on a medication infusion pump. These things are used in hospitals, in operating rooms, in ICUs, in regular hospital wards, to deliver precisely metered amounts of medication. Often these are dangerous medications like opiates and so on for pain management. And so these things have been around a long time. This is not new technology. The old school versions had just analog dials and needles and knobs, and you'd sort of crank it up or down, and there you go. So when digital products started to be a thing, the manufacturers of these said, well, we should put screens on these, and we should put keypads on them, because that will be more precise. Sort of makes sense at first glance, but they decided, all the different manufacturers did this, they decided to use these kind of inexpensive membrane keypads. And if you've ever used these things, they're kind of stiff, they're sticky. So imagine you're a nurse entering a medication dose, right? You're giving someone morphine, and you think you're typing 1, 5. But that key's a little sticky, and you don't realize it, but you've typed 1, 5, 5. This mistake was so common, it got a nickname, death by decimals. So my team and I were supposed to fix this problem. And that's a scary prospect, right? This is not a lighthearted design problem. But someone made a design mistake that killed people. And that's what's at stake when you're designing in healthcare. That's kind of a humbling thing to think about, isn't it? So healthcare's a difficult environment. Hospitals are crazy design environments. They're, I mean, obviously things have to be sterilizable, so there's, you don't want to put seams and cracks on things that the bleach gets into. But healthcare workers are so overstretched, right? Even outside the United States, every country you go to, they're working long, exhausting shifts, I mean, especially after COVID, but even in general. Usually they have very few resources, right? They don't have enough stuff to work with. They're dealing with people who are sick and in pain and their families who are scared. And, we're not always at our nicest when we don't feel well. So healthcare workers take a lot of abuse. They befriend their patients and get to like them and then watch them die. This is a hard day at work, right? These folks go through a lot. And everything they do requires filling out a form. And you know what? All those forms are badly designed, and they take 3 times as long as they should. And they get interrupted 3 times while they're doing it. This is not easy work. They're also constantly interrupted by families and patients and colleagues who need things. Sometimes they have competing incentives, right? They're trying to keep costs down and keep usage down. At the same time, they're trying to take care of the patient in front of them. They're surrounded by alerts. Everything in a hospital room beeps. And it beeps constantly. They're just bombarded by alerts and alarms, so they just learn to ignore them. They filter them out, so it's hard for the ones that actually matter to get through. They have difficult lighting. They're trying to read these, inexpensive little screens through mask and fogged up glasses and face shields. They're trying to use a touch screen through gloves that are too big because they're out of the right size and they're covered in goo. This is not an easy work environment. So device manufacturers try to make up for this by putting guardrails in the products. But what they tend to forget is something that all of you who do enterprise design know, which is that the design's only about 90% done when you sell the product. The configuration is the last 10% of the design, and boy, does it usually get neglected. So what happens is you get all these defaults that don't make sense. Should your electronic medical record reject it if you say that your patient weighs 1 kilogram? Yeah, probably so, if they're an adult. But what if you work in the neonatal intensive care unit? You have to be able to enter that kind of weight. Something that says, no, you can't administer that much of a pain medication to a patient because it's not safe might make sense in a lot of settings. But when you're doing end-of-life hospice care, come on. You have to be able to give people that discretion. So in healthcare, we have to design for overstretched people in difficult environments who could make mistakes, but we also have to respect their professional judgment and give them flexibility for when things don't fit in the preset boxes. That's tricky. Then there's designing for the patients, right? When we're designing for patients, patients are tired. They may have a condition that's exhausting. They may be scared and overwhelmed by a new diagnosis and confused by a bunch of terminology they don't understand. They feel helpless because the healthcare system isn't really designed to make them feel in control. It's designed to be efficient. They might have brain fog as a symptom of their disease or a side effect of their drugs. Their disease itself could be giving them motor skill issues or memory issues. There's a lot going on when you're a patient. And to pile on top of all of that, healthcare workers might not take them seriously for various reasons. Maybe they have a rare disease that that doctor has never heard of, and so they don't quite believe them. Or their symptoms just don't fit the typical textbook medical outline. Or, the medical professionals are responding to that person's race or gender or age or weight or other things that just make them tend to get worse care in the healthcare system. That's a lot to deal with. So patients are advocating for themselves at the time when they feel the worst in their lives. And some patients are kind of upset about this. And so in healthcare, we have these wonderful people called patient advocates who really have created quite a groundswell movement around involving patients in healthcare. And they have a battle cry that I love. which is nothing about us without us. You're not allowed to have a medical conference without patients in attendance. How dare you? How are you designing that clinical trial without patient input, right? Patients are angry with good reason. And what's wonderful is that these loud, obnoxious, wonderful, driven people who've given their time to this movement, they're actually getting healthcare to move. We're seeing change in healthcare where a lot of clinical trials are designed with patient input, right? We're measuring patient experience more. There are scholarships to let patients attend medical conferences, right? We're not where we should be, but things are going in the right direction, and that gives me hope. And you know, nothing about us without us seems like a thing we could apply outside of healthcare, doesn't it? But when safety is paramount, our usual user-centered design practices are not enough. Including patients is not enough. We have to have other processes and procedures in place, and that's why healthcare and other safety-critical industries have cultural norms and procedures and regulations that make us go a step further. So, going back to that medication infusion pump for a second, if you look at a nurse who's adjusting someone's medication dose, and they have multiple bags of medication hanging on that IV pole, the first thing you're going to see that nurse do is called tracing the lines. She's going to reach up, check the label on that bag, and then she's going to trace that line down and make sure she's adjusting the right line and the right medication. That's a safety issue. She needs to know where it came from and where it's going. This concept of traceability is also something that applies to medical product development. Regulatory agencies require that you document and demonstrate that everything in your product is there for a reason, and you know why it got there and how it got there. So if you have a feature, they want to know why that feature is designed as it is. Why is that feature even there? And you have to be able to say, well, that is there, and it's designed this way, because we had these requirements. And these requirements are there because we saw these things in user interviews. We got these complaints from our customers. We saw these safety issues in testing. That's why it's there. Now, you have to document all of this in your quality management system. And you have to document who made this decision. And by the way, what's their job description and what's their qualification for making this decision? And oh, quality management systems are a nightmare. This is bureaucratic craziness, right? Most companies in practice probably spend at least as much time documenting this stuff as they do accomplishing the intent of this. So I'm not saying we need to adopt quality management systems wholesale, but there's something there. Shouldn't we be able to say, that's why that's there? That's where that came from? Shouldn't we be able to document and explain a better reason than, oh, well, Apple and Google do it? We should have a better rationale than that. And you know what? It's also really handy to have this stuff documented, even if it's a pain. Because a year from now, when you're like, why did we do that? You don't have to have those 16 meetings to try to figure out why you made that decision a year ago, because it's all documented. So I think most teams can accomplish the spirit of traceability with, you know, a couple of wiki pages and, you know, maybe a tweak to their product requirements doc and some better habits, right? So I think this is a thing that we can adopt and improve on. If you're shipping a medical product, you also are required to do risk analysis. And I don't mean brainstorming what's the stuff that could go wrong. What I mean is really investigating it, looking at similar products. What are the issues that they've encountered? What are the issues that we saw in user research? Coming up with a pretty exhaustive list of what could go wrong. How likely is that? How severe is it? And what will we do about it if it happens? Right? You have to document all of that and have a plan. There's an assumption that a lot of people don't necessarily expect, right? We're used to the idea of a court where you're innocent until proven guilty, and we kind of treat our products that way in most of the world. Well, in healthcare, the assumption is that your product isn't safe until you've proven that it is. Now imagine if we made that assumption in most product development. That may be a bit much for most cases, because honestly, most products are not as high risk as healthcare, but there's something to be learned there, right? When was the last time you did a real risk analysis? Now, once your product is in the market, you're still responsible for proving that it's safe and continues to be in real-world use, because that's different from what you did in the clinical trial. So you have to do something called adverse event monitoring. Now, this means you have to have systems in place for reporting anything that goes wrong while someone is taking your product or using your treatment. So if they have a new symptom while they're using your product, even if it's unrelated, you have to report it to the regulatory agencies. And you have to train all of your employees and your contractors in this. So somebody sends a complaint to your Twitter account, report it. Somebody at a party mentions an issue in the hearing of one of your employees, report it. It's very, very serious stuff. And so there's a regular review of all of the safety issues that are coming up, and that has to get folded back into product development. Now, do you even know if your company has any kind of incident reporting? I'm guessing most don't even have one. If someone is harmed by our products, do we know who to tell and who's responsible for that? Seems like most of us ought to at least have a procedure, even if there's not a regulatory requirement involved in that, right? So you might be thinking, okay, Kim, this stuff sounds like overkill. I'm designing stuff for ordering takeaway at a restaurant. I'm not going to kill anybody if I make a mistake, right? Probably. What if somebody's got a shellfish allergy and doesn't realize the thing they ordered has shrimp in it? You know, none of the products we do are really risk-free. There's other risks in there. We could be revealing people's personal information, overcharging their credit cards. If we make design mistakes, we could hurt the livelihood of that restaurant owner by doing lousy design and making it too hard to order. There's lots of ways we could be doing harm if we screw up. So I think we should assume we can't predict all those harms and think about what can we learn from safety-critical industries like healthcare to get better at safety? Because just user-centered design isn't quite enough for us to ship things that we know aren't going to hurt people. Not to say healthcare is perfect, it's not. But it would be a lot worse without these procedures in place. So I think there's more we can do as an industry to prevent that. Now, another thing that we talk about a lot as designers is having a seat at the table, right? We think that we don't have enough influence over decisions. Other people make decisions we should be making. We don't get enough respect as experts. And healthcare's affected how I think about this, too. You know, maybe we think that we should have the red card to say, you know, that product's out of here. I don't think that design should ship because I'm the expert in it. But how many of you actually have power to do that? Yeah, I'm not seeing a lot of hands, are you? No, didn't think so, right? We don't usually get to say, I'm the expert, this can't ship, right? We don't have that sort of professional power. But you know, doctors are an interesting case study in this. Most doctors will tell you they have lots of constraints on on what they can do. They put up with bureaucratic nonsense just like everybody else does, but they do have much more of a seat at the table in healthcare than we have in the products that we design generally. So why is that? Well, if you look at the sociology of power, the literature will tell you there's maybe 6 or 7 different sources of power. Things like you control a scarce resource, or people owe you have debts that they owe you for. Those are sources of power. The one that I think is really relevant with physicians is something called perceived legitimacy. If we believe that somebody deserves to have authority in an area because of their job title or their expertise or their age or other cultural considerations, generally we'll defer to them, right? If you're in the library and you're being chatty while you're looking at books and the librarian says, shh, that's legitimate, right? We're going to tend to defer to them in that instance. And when a physician has an opinion about something medical, we're probably going to defer to them too. And other medical professionals with lesser credentials will also defer to them, right? So there's an assumption of power there that's based on perceived legitimacy. And you know, I think there's a reason that doctors have lots of perceived legitimacy, because it's not easy to be them. They have to get a graduate degree from an accredited college. They have to do a residency and go through hands-on training that's supervised. They have to take multiple credential exams. They have continuing education requirements that they have to keep up with in order to keep their license. They have a professional code of ethics that is enforceable. You can lose your license if you don't follow it. You can lose your license if you're incompetent enough, too. And that's a lot of credibility, right? Because we assume anybody who's gone through all this probably kind of knows what they're talking about. Not that that's perfect, but it gives us a pretty reasonable reassurance that someone who's taking care of us kind of knows what they're doing. On top of that, they're accountable for outcomes. If we don't get well, if we get sicker after dealing with a doctor, we can sue them for malpractice. And so their livelihood is on the line when they make a decision. And they also have a pretty active bunch of professional organizations out there working to make sure we all see them as legitimate. So there's a lot there that gives doctors power through legitimacy. Now, which of these boxes can we check as professionals? Nope. Yeah, no. Not that one. No, not that one either. Yet nothing, right? We can't check any of these boxes. And so we kind of want to be treated as professionals, but we are not a profession. We don't have to go through the stuff that professions go through. So we're not going to get the same kind of professional respect that they do, right? And there's a reason for that. And I find it kind of interesting that you need all of that credentialing to use one of these things, but not to design it. If that doesn't scare the shit out of you, I don't know what does. I think that's kind of frightening. Like, I would like to think that I and my team knew what we were doing when we redesigned these things. And I think we did a pretty good job, but gosh, I wish that weren't just my judgment. Because, you know, I don't think that's a great thing, right? I think it would be a lot safer if there were somebody backstopping me and my team. I think we should need to be qualified to do this stuff. Now, not all design problems are created equal, right? Not everything is something that will directly kill you if somebody screws up. But, you know, the person who cuts my hair has to pass a test and get a license, because she can pass on disease if she's not careful. That person who installs electrical outlets in my house has to pass a test and get a license because he can burn my house down. And you know, one of these days the world is going to figure out that we're more dangerous than a hairstylist. And I think we should embrace that. I think we are going to get regulated at some point, and I think that we should be. But you know, there are lots of ways that could go wrong, that could happen badly. I think design problems pose unequal risk, right? There certainly is not as much risk in, I don't know, designing a video game versus designing an infusion pump. But you know, even stuff that we don't expect to be dangerous, like say social media, destroying democracy, nothing important. So you know, it's a hard problem. I think there have to be levels of accountability for us and levels of skill that we have to demonstrate. But yeah, this could get very gatekeepy, right? Who sets those standards? I don't know. I'm certainly not claiming it's me. I don't know who that is. And I think getting this community of practitioners to agree on who the heck sets those standards, that's going to take a while. I don't think this is an easy problem. I think this could create barriers to entry in an industry that already isn't diverse enough. That worries me a little bit too. And you know, if we start to get a lot of accountability piled on us, but our authority doesn't increase, yeah, well, that could kind of suck. So I think there's a lot that could go wrong with regulating us, but really I think that there could be benefits as well. I think that if in general we uplift the skill level of our would-be profession, I think we'll ship better things. I think we'll have a better impact in the world. And I think we'll also be able to fall back on that, right? If you say right now, gosh, I have ethical concerns with shipping this thing, I'm not okay with shipping this thing, you're just difficult, right? You're the pain in the ass designer that they don't want to work with anymore. But you know what? If we all have that same position, because we could lose our license for doing it, well, that's a lot harder to argue with, isn't it? There's power in group accountability, right? There's a certain freedom in having that constraint that I think is pretty interesting. So professional power of the sort that we sometimes think we should have takes some legitimacy and some accountability that we don't have. And I think we need to work on what that looks like eventually, or it's going to get landed on us in a way that maybe we don't like. I was working with a head of product recently who was making a design mistake. I've seen a lot, pretty common design mistake. I've seen it, I don't know, half a dozen times before and dealt with it half a dozen times before. It's not a hard thing. This team had usability test data demonstrating that this was a design mistake. And yet the head of product was like, no, it's not a problem. And then she finally said, well, I know this approach is right because there's a paper. Right? There's a publication that demonstrates that this approach works. I was like, oh, there's a paper. Okay. That's the answer for lots of things in healthcare. Anytime you want someone, actually, let me back up. I'll tell you what the paper was. The paper was somebody who was an academic medical researcher, prototyped an app, tested it in their lab with 20 undergraduates, and said, aha, this is what does and does not work in creating health apps, and published a paper on it. Therefore, the team's UX research, right, their usability testing, well, that was just UX research. This was science. Science, right? Because anytime you want to do something in healthcare, the first question is always, what does the evidence say? You want to adopt a new treatment? What does the evidence say? New item on the cafeteria menu? Oh, OK, well, they don't ask for evidence for that. But they want evidence for everything. And I deliberately capitalized that in this slide. Yes, I do know how to punctuate. Because people pronounce this pretentiously, as if it is capitalized. What does the evidence say? They always want to know. And better yet, they want to know, well, was the evidence in a population like mine? Was it in a healthcare setting like mine? Was it published by a PhD from an institution I respect? Right? So there's a lot of evidence snobbery that goes on. And really, the snobbery increases the less somebody wants to hear what you have to say. So this is a thing in healthcare, right? I know that that particular head of product was just not going to respond to the UX research until we could find a paper that was a counter-argument, or until we could very convincingly pick apart why that paper didn't apply to this product, right? So we're never going to meet this bar, right? Because this is a giant roadblock in the way in product development. Because we're not going to hit that standard. We're not going to take the time to do publications on our UX research. We'd never get anything done. And we would, along the way, reveal all of our business information. So what can we do? Well, we can move closer to this standard, right? We can look for supporting literature, right? What can we find? Has someone published on something like this, preferably in the medical literature, although HCI literature will do in a pinch. When we're reporting out results, well, in most companies, they don't want to hear about your methods and your sample and your recruitment, blah, 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 blah. In healthcare, you're hiding something if you're not sharing that stuff. They like objective measures, things like task time, completion rates, error rates. Those things are evidence-like. And if you are going to use a survey of patient experience in some way, you want to use a validated measure. This is a word that gets thrown around a lot. It means somebody has done the psychometric testing to figure out if it's a reliable measure, if you have things like floor and ceiling effects. So statistically, does it hold together? Because just any old survey doesn't quite work from a credibility standpoint in healthcare. And so sometimes you have to adopt those accepted measures, even if you don't want to. Net promoter score. In healthcare, it's not net promoter score, but we sort of have our equivalents, right? So we have to sometimes find quantified ways to measure good experience. And in healthcare, there's something called a patient-reported outcome, a PRO, that they're actually accustomed to using. Because if you're trying to get your treatment approved, and it doesn't affect, say, a lab result or something objective, you can use a validated survey of, say, patient symptoms as medical evidence for the regulatory agencies. So the industry is sort of primed for this notion that you can quantify patient experience in a validated way and have that be evidence. So they're more willing to accept that if you do it in a certain way. So if you want to do this for a UX outcome, you can use good user-centered practices as your starting point, right? Go ask people, what is a good experience? What's a frustration like? And what you do is you listen for those themes and you turn them into a survey with scales, rating scales. You usability test the survey and refine it. And if this is a measure you're going to rely on a lot, you validate it, right? You do the psychometric testing, which is sort of a pain and a bit expensive to do. But if you're going to repeat it, it's more credible. So instead of saying, well, you know, patients in our interviews told us that their doctors didn't listen very well, which is going to get a, what's next, right, kind of reaction. If instead you can say, well, 82% of our patients said that their doctors rarely or never listened, then somebody's going to say, oh, crap, that's a thing we have to do something about, right? So think about the stuff you hear in user interviews, turn it into a survey. It might not tell you anything new, but it makes the stuff you're learning a lot more believable, which is the important point, right? Now, you might wonder, does this matter if they don't already value this measure? Yeah, I think it's a chicken and egg problem. Because if you start to measure it, it kind of sends this subliminal signal that, in fact, you do value it. And if you can come up with a number that says, hey, 78% of the people who used our product feel more comfortable self-injecting themselves with this medication afterward, yeah, your sales team and your marketing team are going to find a way to use that number. And then we start using that number, and that number starts to get more important, and we start to follow that number. So I think it really can help. So the best kind of evidence is the kind people already value. So instead of making ourselves blue in the face about getting people to accept our usability test results, we'll still do those, but let's use the kinds of measures they already respect. So when we deal with healthcare, we tend to encounter it as disease treatment, right? Something's wrong with me, fix me. Or maybe we do the routine stuff to prevent a disease. And a lot of people in healthcare tend to approach healthcare this way too, as basically the disease model. But what's interesting is I was a peer health educator in undergrad. So yeah, I guess I've been around healthcare a while, haven't I? The very first thing I learned was that health is not the absence of disease. It's not just that anyway. It's the presence of optimal well-being, right? We are living our best selves. We are feeling our best selves. That's what health is. It kind of resonates, right? We don't say we're healthy when we just feel neutral, do we? Right? We feel healthy after we have a good exercise session or something, right? There's sort of a positive quality to health. But we don't really measure that in healthcare. We do measure functional ability, right? We measure people's ability to walk a mile or to do their jobs or to dress themselves or things like that. So we do measure something beyond symptoms. But we don't really measure what it is to be optimally well. And so it's hard to get people to focus on it if you don't measure it. So I used to lead the product and design teams at Patients Like Me for a few years. This is a social network for patients and caregivers that does a lot of research that's sort of groundswell, crowdsourced research. And so we decided we needed a credible measure of what that well-being was. And so we decided to create a PRO for what is optimal well-being. And so we recruited a bunch of people, and we asked them questions like, what is health? And what does it mean for you to thrive? What is life like if you're thriving? And they told us things like this. Health is the ability to enjoy life with minimal impact from your conditions. It's feeling good about life and who you are. Thriving is even more than health. It's looking forward to each day with desire. Wow, I want to feel like that, right? Don't you want to seize life with that much zest? We heard lots of things like that. And so we distilled all the themes down and came up with a measure. And the essence of that was these themes, right? I'm doing well if I don't have anxious or depressed mood, if I'm not in pain, if I can sleep. I'm doing well if I can get around, if I can sleep, if I can manage my personal needs and manage my emotions and meet my responsibilities. But the really interesting theme was a handful of things where people said, I can usually feel connected with other people. Yeah, this doesn't get measured in healthcare. I feel good about myself. I find meaning in my life. This is what people think it means to be healthy. That's a whole lot more than you've ever discussed with your doctor, I'm sure. And this is the stuff we should be measuring, and this is the stuff we should be designing to. Certainly we have a lot to do around preventing and treating disease, but this is the really good stuff. And I think this is something that we can do as designers as well, because healthcare needs to get better about disease and this stuff. As designers, there are things we can do to get better about safety and usability. And yet, that's not the purpose of design. The purpose of design is to make life better. So I would say we should be designing to help people thrive. Have you looked at whether your work helps people feel connected to others? Have you looked at whether your work helps them find meaning in some way? Right? Are we helping people thrive? I think it's a good question. So here's what I hope you take away. My prescription for UX, if you will. Things I think we can learn from healthcare, right? We can reduce harm through traceability and risk assessment and so forth. I think these are processes we can get better at. I think we can earn power through legitimacy. I think we can treat evidence as a design problem. What kind of evidence will be most persuasive to our stakeholders? And I think we can work toward helping people thrive. Because if we're not designing for health, I mean, if we're not in healthcare, that's okay, but shouldn't we still be designing for health? Because as the saying goes, health is the only real wealth, right? If we're not designing for that, what are we designing for? Thanks for listening.
Thank you, Kim. Will you join me over here? So you realize you are presenting to a bunch of designers, and you gave us a design problem, but not the solution. So one of the audience members was asking about the sticky buttons.
Yeah.
What was the solution you came up with?
The solution actually was to go old school. What we did was we went back to a dial. But it was a dial with guardrails, and they were flexible guardrails. So we had the notion of soft guardrails, like, are you sure about this? And hard guardrails. But you could also find a way around that configuration if you really needed to. Yeah.
So what was the advantage with the dial? That you're getting visual and physical feedback?
Well, I mean, if you grab a dial, you kind of know I'm turning it a little or I'm turning it a lot, right? There's some sensory feedback there in a way that you don't get with the sticky buttons. It made errors more evident. So yeah, that was where we went.
Brilliant.
Yeah.
You started your talk, and you said you worked out that maybe 60% of the work you'd done had been within healthcare, and that it had influenced other work you've done.
Yeah.
Could you give an example of how this has influenced non-healthcare work?
Sure. I mean, I would say it influences how I approach my teams. So, for example, I think traceability is important. And so this is an expectation I have of a designer on my team, whatever industry it's in. I want you to be able to tell me where that came from, right? You need to be able to justify that, and we build that into our processes, right? So I try to take some of these things from healthcare and pull them into other industries as just good practices in a lighter weight way, right? Without all the crazy healthcare bureaucracy, because that would drive us nuts. But yeah, I think we can just adopt some of these things in smaller ways and take the principle of it to do better work.
Right. Now, this notion of becoming accredited, someone here asked the obvious follow-up question, which is we rarely make, as designers, we rarely govern the whole process. There are developers and product owners.
Yeah.
Are they accredited? How would this work?
Yeah, that's a good question.
You brought it up.
Yeah, I know. It's a good question. That's why I said it's a hard problem. I think that, you have to be licensed in order to engineer a bridge. You don't have to be licensed in order to engineer air traffic control software. Seems like that's inevitable too. I don't know how it will take shape. I think that there's a level of accountability in software that other industries have that we just don't. And I think that's bound to change eventually. I do think it would be a problem if, I could lose my license over a decision that somebody else made. That wouldn't be okay. And so that's why the accountability and the authority have to go together. But I also think there's power in saying, hey, I am accountable for this. I can't actually do this work without authority that goes along with it, right? So it's a hard problem.
It is.
Yeah.
By looking at healthcare, and there's a stake, someone's health, sometimes even their lives.
Yeah.
It seems that is a good way of noticing things about design that are otherwise quite invisible. Are there other areas that we could look at? Other domains than healthcare that would...
Sure. I mean, I think any safety critical domain, you're going to see similar things to healthcare. I think that folks who work in finance will probably tell you there's a lot of, security practices and so on that, maybe we should be thinking of in other industries as well. So I do think that various industries have sort of higher needs for certain good practices than other industries do, and we can look to them as models.
Fabulous. Fourth time from Business to Buttons participant, speaker. Are you coming back?
If you'll ask me back, sure.
A big round of applause for
all.
Kim Goodwin. Thank you so much.